I think
So you're probably good.
this is a good guess. Well,
All here. Everybody's coming is here. Okay. You guys want to start? The faster we start, the faster we finish. All right.
I've heard good things.
Oh, good. Well, I have something to live up to. I actually didn't plan this to be given like today in this specific week, but it just happens to work out well because this is everything that's like, going on around us with the protests and such. But topic is volatile anesthesia and climate change. Come on in. Haven't even started yet. Here, there you go. The background to this lecture is basically, I barely remember this, so you guys probably don't, but back in the 80s, the ozone layer was a big thing, and there was a big hole in the ozone layer that was like over Antarctica, and it was this huge deal, and so all the countries in the world got together in the Montreal Protocol, and they like made this consensus agreement to limit the use of chlorofluorocarbons, CFCs, which were responsible for ozone depletion, they were in everything, like especially aerosol and refrigeration type things. And it was really successful, and you know that because now people don't really talk about the ozone layer anymore. It's kind of a thing that used to be, but it seems to have rebounded. That was like in 1985, and then 1997 there was the Kyoto Protocol, and that's when countries started to address their focus to greenhouse gas emissions. And then the follow-up to that was the Paris Climate Accord, which you guys are probably all familiar with. That was from 2015, and that was a multinational commitment to reduce global greenhouse gas emissions, which is still ongoing, and that's part of the the subject of like this week's climate protests and all that stuff. But throughout this, what about all the gases that we use? We use a lot of them. That's like almost the whole field, right? Everyone's had a chance to get familiar with volatile anesthetics at this point right now. I'm guessing everybody's familiar with the clinical uses and the differences between them clinically. Okay, well this will touch on what happens after they leave the patient. So basically, anything that has to do with medicine was just exempted entirely from any kind of regulatory oversight. That includes the halogenated anesthetics, nitrous oxide, all that stuff. The exception is that OSHA, the Occupational Safety and Hazards Association, Health Association, does regulate the occupational exposure that people who use these agents have. So they're all scavenged from the direct operating room environment, and that's why there's limits that everything has to stay under in terms of parts per million. But once they're scavenged from the immediate environment, they're vented just out of the building, out into the world, never to be seen again. But interestingly enough, it's not just carbon dioxide that's a greenhouse gas. All of our volatiles are potent greenhouse gases. Some of them also even contribute to ozone layer depletion. And we'll start with just a quick couple of definitions. So one thing we'll talk about in just a minute is the atmospheric window. That's the infrared spectrum of radiation that leaves the Earth's surface. So the sun heats up the Earth's surface at night. The sun is on the other side of the planet. That heat is radiated back out into space, and it has its own infrared spectrum. That's the atmospheric window. Radiative forcing is when that heat that's going back out to space gets trapped by gases in the atmosphere. So that's basically the greenhouse effect. So something that has a radiative forcing effect just means that it will absorb heat it will absorb infrared radiation in the spectrum of the atmospheric window. So it just absorbs heat coming off the Earth's surface. Back in 2010, maybe this was 2012, some scientists at the Jet Propulsion Lab at Caltech studied the absorption spectra of the volatile anesthetics. This is really kind of the first work that was done to really look at what their greenhouse gas potential was. And this is a little bit of a complicated graph, but if you look across the bottom, those are infrared spectra and in terms of wave numbers. And then you'll see absorption spectra spikes that correspond to different wave numbers. And basically everything in gray are the volatile anesthetics that we use. So that's ISO, DES, and SEVO in gray. And then the red and the blue are the ones that we don't use anymore, like halothane and enflurane. And as you can see, with some small exceptions, they pretty much lie within that atmospheric window pretty squarely. And so they quantified the actual global warming potentials for all these different gases and how long they hang around in the atmosphere and whether or not they deplete the ozone. And so if you look in this box, this is the GWP 100, the global warming potential over a 100-year time span. So these numbers are all set against a reference number of 1 for carbon dioxide. So for instance, at the very bottom, sevoflurane is 130 times more potent than carbon dioxide as a greenhouse gas. All of these numbers are much higher than 1, you can see, but if you take a good look at desflurane, which is the second one up, you'll notice that that's far and away the highest. That's 2,540 times more potent than carbon dioxide. I didn't know. What's that? How do they get that number? The short answer is I don't know. But the slightly longer answer is I'm guessing that it has to do with comparing the atmospheric lifetime of the gas to that of carbon dioxide and the potency of its infrared absorption. Good question, though. Good question for the folks at the Jet Propulsion Laboratory. Yeah, phone them up. And then I put the ozone depletion potential in a box up here just so you can appreciate that DES and SEVO, no ozone depleting potential, but nitrous and isoflurane, small but not zero. In a different form, these are the different GWPs for the 4 gases that we use. Sevoflurane is the lowest at 130. Desflurane is the highest at 2,540. I'll repeat, desflurane is the highest at 2,540. I heard a rumor that shows up on an exam that you guys take at some point or two. Nitrous, 300. Carbon dioxide, like we said, 1. So let's reframe this into like a little bit easier to understand format. This table is I think pretty useful because it compares how many miles, what a Mach hour of anesthetic at a certain flow rate would be if you got in a car and drove a distance. So for example, if you ran a full Mach of sevoflurane at 1 liter per minute for an hour, it would be like driving a car that gets 24 miles to the gallon for 4 miles. And if you ran a Mach of DES at 1 liter per minute for an hour, it would be like driving 190 miles. And you can look back at this. If you forgot your flows up at 2 liters, and you get up to 400, and then on and on and on it goes. And so you think about, well, maybe I want to drive less because it's the right thing to do. Well, make sure you're paying attention to this because It's not going to matter if you blow it with your gases.
I'll drive less so I can use more DES.
Yeah, well, as long as you're thinking about it like that. You ride your bike because you love DES that much. So then they started looking at like the life cycle greenhouse gas emissions for the different anesthetic drugs. And this is the greenhouse gas emissions associated with the production of the three different halogenated volatiles, and they throw propofol in there just for comparison. But the light blue is manufacturing the agent itself. The dark blue is the greenhouse gases emissions associated with nitrous oxide manufacturing, assuming that you were in a practice where you'd be using some mixture of halogenated volatile with nitrous. And then they throw in packaging and transport, and then drug delivery, which for DES and propofol is the electricity needed to maintain either your pump or your vaporizer at 39 degrees Celsius for 24 hours a day, 365 days a year. But now look at this, and then here is the greenhouse gas emissions associated with manufacturing and use. So manufacturing all fits into that little blue part all the way on the left there, and then the light pink is the greenhouse gas emissions associated with the use of the volatiles, and then the darker red is nitrous oxide. So you can see that DES has by far the largest light pink section. ISO and SIVO are a lot smaller, and you'll notice that the dark red, the nitrous portion for SIVO, is twice as big as it is for these, and that's because this is assumed to be at 2 liters per minute, and these are at 1 liter per minute flows. And so you could even, if you cut your flow of SIVO back down to 1 liter per minute, all of that would be even half the size, including the light pink portion. So you can see that all of the greenhouse gas emissions associated with, manufacture, transport, everything you can think of is nothing compared to what happens when you actually use the gas and it leaves the patient and out the hospital. So how big is this impact in terms of, the hospital and the healthcare sector and stuff like that? This was a study that was published in 2017 in The Lancet, and they looked at 3 different healthcare systems, one in England, the John Radcliffe Hospital, and then the University of Minnesota and Vancouver General Hospital. So 3 different hospitals, 3 different countries, 3 different systems. And they looked at the volume of volatile anesthetics they purchased over the course of a year. And here you can see that Vancouver and Minnesota lean pretty heavily on desflurane, and John Radcliffe just doesn't buy it at all. And then they translated that into CO2 equivalents in kilograms per year. And for both the North American hospitals, it was just under 2 million kilos per year compared to 0 in England. And then the total CO2 equivalents in kilos per year for the 3 hospitals were just over 2 million kilos per year for the North American hospitals, and then 200,000 for the hospital in England. So about 1/10 the CO2 equivalents for the John Radcliffe Hospital in England. And if you want to see this in graphical form, I should also mention here that the English hospital did about 50% more cases than these hospitals. The North American hospitals did about 20,000 cases. John Radcliffe did 30,000 for 1/10 the carbon emissions associated with their volatiles.
Does it use lower flows?
We
We have a good source here.
Oh, yeah. It is, well, we'll get there, actually. That's the punchline.
The rest of it's not.
Well, yeah. So anyway, so they broke it down into what the whole perioperative carbon footprint came from, and it broke down into 3 categories. One was the energy used to power the operating room and the PACU and all that stuff. The second was the supply chain and waste, and that was like all the things that get opened and thrown away, and like every bottle you pop and all that stuff, of which there's a ton, as you know. And then the third was the actual carbon footprint associated with the volatile anesthetics themselves. And so you can see across here that, largely because of the power supply in England, because in 2017 was largely coal-based, the anesthetic gas portion was only 4%, which if you compare that to the University of Minnesota and then Vancouver General on the left-hand side there, theirs were over 50% and over 60% of their total carbon footprint was just from the volatile anesthetics they use in the operating room alone, nothing else. Of all the things that you can see and touch, 60% in some cases was just from the volatiles themselves. What's that?
What are their energy sources?
So Minnesota is a mix of coal and natural gas, and British Columbia gets most of their power from hydroelectricity. So that's why their energy was only 17%. So, does this matter? I would argue that it does. Over time, over the 10 years of this study, they looked at the environmental impacts of the U.S. healthcare system and effects on public health. And basically, the share of the U.S. greenhouse gas emissions was about 11%. The healthcare sector contributes about 11% of total greenhouse gas emissions. That's including energy production, transportation, all that stuff. So it's actually one of the top, I want to say top 3 emitters of greenhouse gas emissions. If you look at like an individual sector, so it's significant. So going back to the global warming potentials of the different gases, we saw that desflurane has the highest potential. Sevoflurane is the lowest. What have you guys learned about sevoflurane other than what I've told you in terms of, potential hazards? Anything? I'm curious, because I know what I was taught.
It was about compound A.
Compound A is going to kill your kidneys if you don't run it at 2 liters a minute.
Okay. For the CA1s, do they still teach that?
Mm-hmm.
They do?
Most. I've heard some, say you can go under 2 for, the first 2 MAC hours.
Uh-huh.
It's definitely still on. It was on basic.
Yeah.
It's
Okay.
still all over our question banks. It's like,
All right, well, for the purposes of your testing, for the purposes of getting your questions right, just go with that. We can have a deeper conversation about this when the microphone isn't on, if you want. It's an interesting story. Have you guys ever seen The Fugitive?
Yes.
Yeah? The Harrison Ford one.
Yes.
It's basically exactly the plot of that movie. It's kind of cool, in a way. So anyway, addressing the 2 liter per minute flow requirement. Just to keep it short, there are oodles of studies of randomized control trials, meta-analyses, and the short story is that it's not nephrotoxic. Just plain and simple. So these 2 studies, they were just representative, but patients were randomized to either low-flow sevoflurane, and these were using CO2 absorbents that were just potassium hydroxide or sodium hydroxide, strong bases. These are the things that are the most compound A producing. So it was either low-flow sevoflurane, and they were doing this for cases that were over 12 hours long. These are head and neck cancer, free phlegm cases that they knew were scheduled for greater than 10 hours, and sometimes they were 20-plus hour cases. I think the average time was 18 hours. And so they were randomized either low-flow sevoflurane, which is the high compound A group, low-flow isoflurane, which is the no compound A, or high-flow sevoflurane with no CO2 absorbent at all. And so that was like at 6 liters per minute, just through glass balls or something. And so that was just exposure to sevoflurane, but no reaction in the CO2 absorbent to produce compound A. And the bottom line, 0 differences amongst any of these 3 groups with any renal function parameter, renal enzymes, period, across the first 4 postoperative days. 0 differences. So where did this nephrotoxicity come from? It came basically from the manufacturers of desflurane, the competing volatile anesthetic. And this is one of a couple of studies. I mean, the evidence is basically, if you read the FDA warning to use 2 liters per minute for your sevoflurane, it's basically the FDA cites a single patient in a single study as their evidence for the warning. But this is the first human study to show it, and it was a volunteer study of 12 medical students. They were enrolled, and half were going to have desflurane for some period of time, and then they were going to come back, and they were going to do the same amount of time under a sevoflurane anesthetic, and they were going to have their kidney enzymes measured and compared, and only 7 of them completed the study. And I think there was a creatinine elevation in one of them, and they don't talk at all about what their pre-study hydration status was, any of that stuff. Medical students can have a lifestyle variation. And the other thing to keep in mind is that sevoflurane has never been shown to be nephrotoxic. Compound A has been shown to be nephrotoxic in rats. And the rats that were exposed to compound A were never given sevoflurane. They were given pure compound A in 100% FiO2, blown down their tracheas for 12 hours. So these studies don't necessarily translate into how compound A is produced or administered in real life. So the bottom line is at this point, there's an overwhelming body of evidence to support the safety of sevoflurane at low flows, even for longer than 2 MAC hours. We now have new CO2 absorbents that are virtually non-strong base containing. They're point. I don't know which kind you guys use at the university. At Denver Health, we use Amsorb, and that's 0.003% potassium hydroxide. And I have a longer version of this talk where I go into that kind of stuff too. But bottom line is basically virtually no compound A is produced. And even when patients are exposed to it, there has never been any kind of adverse outcome associated with it. And in fact, there's never even been a case report of any kind of sevoflurane-associated nephrotoxicity in clinical use in over 20 years, since 1993. So you should find that reassuring. You're not going to be the first. So then what can you do to minimize your impact when you're using your volatile anesthetics? I've noticed, because I was this person too, that particularly during the induction phase of anesthesia, we all go from mask ventilation for our neuromuscular blocker to set up, and then when it's time to intubate the patient or put the LMA in or whatever, then you put the mask to the side, and then you reach over and you turn your vaporizer to 0, assuming that you're masking with volatile anesthetic, which some people don't, but most people do. And then you leave it there, and you do your airway, and then after a little while, however long it takes you to do that, you reconnect and then turn your vaporizer back on. So my goal when I was a resident was to turn the vaporizer off so I wouldn't waste the gas into the room and stuff. And then I thought about that for a little bit, and it occurred to me that just because the vaporizer is off, you still have your flows up, and all of that volatile anesthetic that was loaded into the circuit just continues to spill into the room during that time, which, is bad for Mother Earth, like we talked about, but it's also like blowing in your face, it's blowing in the circulator's face. And, that's probably not good for you over the course of a career. So, for your own personal sake, like for my own personal sake, what I do is instead of turning the vaporizer off, I reach over and I just turn the flows off. And I'm pretty sure that the vents that you guys have here have like a pause button on them, which is pretty cool. Wherever you go now, certainly other sites don't necessarily have that function, but and future workplaces may not have that function. So just something to think about. But, the pause button, that's what it's doing. And the nice thing about that is you connect your circuit once your airway is complete, and then you just turn your flows back up. It's already charged. All that volatile is going to reach the patient. You're going to achieve, your steady state anesthetic much faster. You don't have to recharge your circuit with more gas, etc. When you've reached your maintenance phase of anesthesia, for many cases you can kind of aim for closed circuit maintenance, and the key to that is just doing a basic thumbnail sketch of what you think your patient's oxygen requirements are going to be. Assuming normal metabolism, they're not in a hypermetabolic state. That's going to be about 5 milliliters per kilo per minute. So for like a 70 kilo patient, that would be like 350 milliliters of oxygen per minute that they would need. They're going to consume, so you can adjust your flows based on your desired FiO2 so that they're getting 350 milliliters of oxygen per minute, and then the rest of it will just circulate around through the circuit. And then nitrous oxide isn't used too much here in Colorado because of our elevation, and it loses its effectiveness. But the use of nitrous is also going to increase your environmental impact, mainly through the atmospheric lifetime, which I don't remember if we touched on that, but that's 114 years. So the take-home points that I think are going to show up on your exams are desflurane has the highest global warming potential, and it's like 40 times that of sevoflurane. It's not like they're kind of close to each other and des happens to be the worst. It's like 40 times higher than sevoflurane in its global warming potential. Sevoflurane is the least. And then in terms of atmospheric lifetimes, sevoflurane is the lowest at 1 year. So not only lowest global warming potential, lowest atmospheric lifetime, 1 year. Desflurane is like 14 years, and then nitrous is like 114 years. So we'll all be, anytime the nitrous dial gets spun, just remember, we'll all be long gone by the time that's out of the atmosphere. And so this is, I thought that this was just kind of useful food for thought, because sometimes people try to do the right thing. And last year in 2018, there was a report that came out that everybody likes to cite by the Intergovernmental Panel on Climate Change, which was like a UN Commission report. Well, all these climate scientists, and this was the thing that showed that, all the disastrous things that will happen that everyone's afraid of will probably happen a lot sooner than we thought. And that if we want to avoid, these climate catastrophes, the global goal is to reduce our carbon emissions by like 45% by the year 2030. So just over 10 years from now. And I was like scratching my head and I was like, man, I don't know how to cut out like half of my carbon footprint, because you can like turn the lights off for a few minutes a day and like take shorter showers or like ride your bike or something. But like I feel like that's pretty small. But over the year from 2018 to 19, last year, at Denver Health, we switched over from using primarily desflurane as our anesthetic of choice to not using it at all, really, to using primarily sevoflurane. And we reduced the carbon footprint of our volatile anesthetics by 80%. And then thumbnail sketch, if you put that into the context of the perioperative area, assuming that our waste stream and the energy consumption is pretty much steady from year to year, that's like about a 40% reduction in our perioperative greenhouse gas emission profile. And of the entire hospital, the perioperative area is the most carbon intense area. So that was pretty amazing, because if you look at it in the context of that IPCC report, in 1 year, just on how people turn the dials at work, we've almost achieved that reduction of 45%. What's up?
Can you talk the methodology of putting something on the smokestack to sequester what we are using?
Yes. So that technology exists. It currently is only used in like 5 hospitals in Canada. And the reason why is that no one knows what to do with it. So it doesn't go on the smokestack, but effectively it does. It goes in the HVAC system, and it can be adsorbed and sequestered. And ideally, I mean, I think what people would like is for it to then just be reused. Obviously, there's going to be serious corporate opposition to that. So, I wouldn't be too hopeful that would happen. And then similarly, there's like other, inert gases like xenon and stuff that would be, potentially used, but there's limitations to that too.
When you hit the pause button, you don't still have to turn the flows down on the vent, do you?
I don't think so. I've never used the pause button though.
It's on trees.
Mm-mm. There's just the old silence alarms button. That's pause alarms. That's what you're thinking of. Do you guys have any questions? I feel like I was going to mention something else. No. Do you guys use those much? No.
At Children's, they totally took it off of
Yeah.
every machine.
Mhm.
You have to go first, we get it if you need it.
Mm-hmm. I mean, my opinion is that probably, and this is just from like talking to other people at conferences and stuff, is that probably within the next 10 years, I would be a little surprised if DES is even manufactured at all. Because I think that like it just won't be worth the manufacturer's effort to do it. Because there's like enough awareness now of the environmental impact. And then on top of that, the other thing I should mention is that it's way cheaper to use any other gas than DES. Like even sevoflurane, by switching to that gas as our primary anesthetic at Denver Health, we saved like 50% we saved $160,000 just by spinning the yellow instead of the blue. And we were getting a deal on our DES too. So, I think that like, and the other thing too, in terms of like its clinical utility, the argument is made that like, well, the wake up time for desflurane is so much faster, and that's why people like it. Well, that's something that you can learn in like a few cases of how to use it, and like the studies that demonstrate that are like using a full MAC of gas until the very same moment, and then like timing how long it takes the patient to wake up, which isn't how they're used clinically anyway. So I think that's like fairly weak. And then you probably, those of you who like have used quite a bit of DES have noticed that like anytime you run into a respiratory problem, you're turning it off and turning on the SEVO anyway. So I don't know. I don't really see much clinical utility anymore, but that's just me.
What about nitrous?
What about nitrous?
Other than on OB, where I sometimes utilize it for supplemental labor.
Uh-huh.
Do you find yourself ever utilizing nitrous in the OR maybe at the end of your case, last few minutes to find a little bit of time to?
I think I did that in early 2012. So not since then.
But there are quite a few times that we use nitrous.
I've seen more of that now. It's like you get 5-10 minutes out, and you look over, and now you're 50-50 O2 and nitrous, and your C-goes at half the MAC, and the argument is, oh, they're going to wake up faster, and we're waiting to see the other stuff. But I'm not sure C-go really comes up all that slowly in the next one.
So
If you ever use nitrous in
no, I don't use it. It's not part of my practice. I think that if you were at sea level and you could take advantage of the analgesic properties of nitrous, you could maybe make an argument. But also there's so many contraindications to nitrous too. You have to sit and think. They're like, well, is this a GI case? Is this a middle ear case? Does this patient have a pneumothorax that I don't know about? And that's half of the cases that I do are excluded there. And then I don't think that achieves anything that you can't learn to do with just practice with, the halogenated agent itself. I mean, yeah, there is a second gas effect, but is it a huge deal? I don't think so. I think that could be maybe a somewhat useful crutch for people who are in the learning phase of when to properly time their wake up, potentially. But, as far as a tool to bring with you forward into your practice, I'd be surprised if you needed that.
I remember vividly working with you in Denver Health and doing just that, and then you were like, yeah, this is what CA wants to do, and you should just learn how to time and call. and that has served me well, it served me well.
Yeah. But I mean, the point of this is not to slap your hand for doing anything. Is just to be thoughtful, because most people, I'd say, almost everybody goes into medicine because they want to be a force for good in the world and do the right thing. And so if you're trying to exercise stewardship for your patients, that goes beyond just the patient in front of you. It extends to your community, the earth that you live in, and you having chosen the specialty that has by far the greatest environmental impact in a sector that has very large environmental impact, then I just encourage everyone to be thoughtful with, their anesthetic choice and how they use the tools at their disposal. And, you want to just do a good job and just be conscientious. Any other questions? Okay. Highest global warming potential, desflurane. Longest atmospheric lifetime, nitrous oxide. Take those 2 points home.
Thank you.
Yeah.
People will tell you to not do that. What? Well, right under 2 liters per minute. I don't remember it was rarely above 1. Ever.
I do have a photo of my hit list.
We told her to go to lecture. I told her to go to lecture.
Yesterday when I
Oh, nice. Okay, sweet.
Today.
Did you find the call room? Or do you want me to show you? Okay, sweet. It's not bad. It's like so much better than the sticky call room.
Yeah.
Everything's better than the sticky. Yeah.
I like the sticky part. But
Yeah, that is nice. And a desk.
Not bad so far. Hopefully you can just like two kitty transfers in the morning. Two what? Two kitty transfers.
Like 11.
My first one says great. Are the champions? Are they still in house? No. Nice. They're not.
Yeah.
If any of you have not donated to the ASA pack yet, you're incorrect.
Where do you think you find it, Dr. Leader?
One.
Oh, wait, I bet this is it right there.
Someone up in a sticky who had like emo
6
hernia.
days. You can donate $1.
And then,
No, just donate $1.
oh, then we did that case. Like, yeah.
they died.
Oh, no.
That's casual bad. You want to
Yeah,
talk
yeah,
about
no. They were fine. There was nothing in there. They
Okay.
didn't find anything.
I'd rather have
And then last
Yeah, we're doing
Sunday night, there was like a emergent crazy.
Yes. Good work. There you go. Rose needs to get started on that as soon as
Get him
possible.
started early Mamu and he just did a case basically. Yeah, you guys want food or booze or anything?
Bring booze if you want.
But if we format it, it erases everything.
They'll probably be doing stuff to like.
We're up at your house, in your apartment. We're not doing anything for you, but okay. I'm off for a week. No training. It's on yourself. Oh, good planning. Yeah, I'll tell you. You just got it. It's all good. Make sure to take
Hey team, I'm Jessica Beatty. I'm on the CA2s in case you haven't met me. So today we're going to be talking about an unfortunate case I had over at the VA in the fall of my CA1 year, so that hopefully you all can learn from my mishap. So just sort of outlining, the purpose of an M&M conference, I just highlighted something that I always feel is valuable to say, that it's non-judgmental, and I changed it. I think it was like a presentation, but I changed it to a discussion because I'd like you guys to feel free to ask questions throughout. No need to wait till the end. It's just sort of an overview of what we'll be doing and talking about. So, history of present illness. It was a 68-year-old gentleman over at the VA hospital, the new one. Again, followed my CA1 year. He was a 40 long-standing smoker. He had COPD, utilized oxygen at home, had coronary artery disease, had a recent diagnosis of lung cancer, and within that same week that I saw him, he had just had a right-sided lobectomy, and then was coming back because they had accidentally injured the thoracic duct during that lobectomy, so he was coming back to have that repaired. As you can see here, he was meeting SIRS criteria, so he was feverish, tachycardic. He wasn't hypotensive, but he had pretty significant leukocytosis, and then his blood cultures were pending at the time, and they later came back positive. Again, we were going to the OR for repair of that thoracic duct, and we were going to be kind of utilizing the same small right-sided thoracotomy incision. Out in pre-op, I can totally mentally picture him. He was Rigering in bed, and we were going to do an epidural for post-op pain relief, and realized that he wasn't going to be able to sit up and support himself. He was that weak and sick. So then we decided to try a lateral position, but then came to the conclusion that we were just had a high enough concern for bacteremia that we didn't want to place it. So rolled back to the OR, placed the 5 standard ASA monitors. We did not do an arterial line. Kind of used an induction plan that we're all pretty familiar with, including a paralytic, and then placed a double lumen tube with gyroscope, and then used a fiber optic to confirm it. Collapsed that right lung, moved him over into the left lateral position, and then used sevoflurane for maintenance, probably at 2 liters per minute. He did receive 5 units of prophylactic sub-Q heparin as we rolled back, but otherwise he had normal coags. That anesthetic plan that I just described went off without a hitch. Shortly into the maintenance phase, I realized that we weren't monitoring his temperature, and I thought that, given the fact that it was a thoracotomy incision, the operating room was cold, at that point I was just really concerned that we monitor it. So I put in a nasal temp probe, and I kind of start like that because over at the VA they, I think at that time either they didn't have nasal temp probes. So I had come up with this clever thing where I cut the plastic tubing off of the esophageal temp probes and sort of used that inner string in there to put it into the nose. It's a little more rigid than the nasal temp probes we're familiar with here, but pretty darn similar. And after I did that, he had significant epistaxis. I mean, pouring. He's in the left lateral position, so it kind of poured out, but held pressure and it resolved, in the anticipated amount of time. And then surgery proceeded without complication. Got to the end, he met all the extubation criteria, so we extubated him. ... Shortly after extubation, my attending was off in the corner chatting with the scrub nurse. The entire surgical team had actually left the operating room. And I remember looking at his belly, and it was, paradoxically moving in and out. So with inhalation, it didn't, move out, it was moving in. And I could just tell something was wrong. This is actually one of my proudest moments in this whole case is the operating room nurse said, "Hey, do you want to move him over to the gurney now and take him out to pre-op?" I said, "No, I think something's wrong. He's still saturating at 100%, but in my mind, I just had this gut feeling something was wrong." And then shortly thereafter, he precipitously desaturated to the 50s and then the 40s. Me and my attending empirically treated what we thought was a laryngospasm with positive pressure with the circuit mask and then a small dose of succinylcholine. It didn't improve, so we pulled the glycoscope back over and attempted to re-intubate him. It was at that time, under direct visualization with the glycoscope, that a very large blood clot sort of spontaneously rose up out of his trachea and was moved to the side, and then we intubated him. But at that point, he had desaturated enough that he went into a bradycardic arrest. So we initiated high-quality chest compressions. He ended up getting 5 minutes of CPR, 1 shock for pulseless ventricular tachycardia. We did 3 rounds of epi. We did get ROSC, and we took him to the surgical ICU over there at the VA. He was moving all 4 extremities, and when they came to see him the next morning, they were able to extubate. He did die 2 weeks later from complications of sepsis and ARDS. It turns out I don't think they were able to fully repair that thoracic duct injury, and so he ended up dying from complications of that leaking into his thoracic cavity. So I just, in reflecting on the case, posed some diagnostic and therapeutic questions that then led me to some clinical pearls that I hope to share with you guys. So kind of the 2 main questions I had was, has this situation been described before? Nosebleed leading to this really significant clot. And then at the time as a CA1, it really was important to me to know what resources I had in an emergency. Because you could imagine that was my first day in the thoracic room. It was my second 1-lung ventilation case, my first real intra-op emergency. So it was very impactful, and I just really wanted to make sure I knew better what to do in an emergency like that going forward. So did some research at the time, and then again in prep for this presentation, and it has been described actually as a name. Dr. Black over at the VA, I don't know if any of you guys have met him, he's such a wealth of knowledge, but he's like, "Jessica, there's a name for this, go look it up." And it's called the coroner's clot. It's an occult clot that hides behind the nasopharynx, posterior to the soft palate. Usually happens in nasopharyngeal or trauma surgery. Historically found by the coroner, hence the name. And then you guys, as the forewarned anesthesiologists, when you have high-risk cases, like a nasopharyngeal surgery or a trauma case, we'll just carefully suction and then maybe even pull your, direct laryngoscopy or your glycoscope over and visualize the pharynx before you extubate. I know that I've had a few other cases that I consider high risk that I have actually pulled the glycoscope over and just looked one more time. So aggressive suctioning, or at least careful suctioning, and then just visually looking to confirm that you don't have a clot either in the nasopharynx, or our suspicion was that it may too have just formed directly on top of the cuff was another option. One article I found said that you can flex the neck forward to really, potentially bring a clot hiding in the nasopharynx into view to remove. And then in terms of the question about what resources are available to me, you can really delve into the world of cognitive aids. There's a lot of research about cognitive aids, which is basically just a spreadsheet for specific emergencies in anesthesia and what to do, what you should be thinking through. The one that I found most valuable is one that Stanford creates. It's called the Stanford Emergency Manual. I gave this presentation at the VA, and I had a few of my fellow CA1s just find a great deal of, I don't want to say comfort, but just found it very, very helpful, the Stanford Emergency Manual. I actually keep it pulled up as a tab on my phone. That being said, there are mixed reviews about the efficacy of cognitive aids, like actually in the emergency situation. You can imagine that they can be too wordy, or it distracts the team leader from actually dealing with the situation at hand. But it has been shown that, familiarity with the aid, practicing in a simulated situation with the aid and the team that you're going to be working with is helpful. But more importantly, I think it was just helpful to have something concise to look through. If I'm dealing with hypotension or hypoxemia or bronchospasm or anaphylactic shock, what should I quickly do, and then what should I be thinking about? So this is just an example. You can Google it. You can download it for free. And this is just an example of, I love it. It's like really concise, like call for help, call the co-cart inform the team, and then just some things you should do first. And again, especially as a CO1, that was just really helpful for me. I know, especially at Denver Health, when you run into a lot of pretty scary situations really fast, I just always like to review a couple of these right before I went into work. Other clinical pearls, especially in talking, so we get a faculty mentor when we do these presentations, and Kara Crouch was mine, and she helped me kind of elucidate some of these, but just thinking about the fact that some of the benign routine things we do to patients can have some pretty serious consequences. So, putting in central lines, you can get a pretty significant hematoma, you can go through the external jugular vein. Putting in peripheral IVs can be traumatizing. She had a case apparently in the surgical ICU last week of a bunch of arterial line attempts, and the patient got compartment syndrome from that. So just to be thoughtful about, again, the benign things that we do can have more serious consequences. I always say, I've always noticed when we pull the endotracheal tube out of the mouth, there's a lot of blood on it, and I always assume it's just from maybe trauma as we put it in, but I often thought too, maybe it's from all that aggressive suction maybe right before we extubate them. Just be thoughtful about as you hit the back of their oropharynx, even just right before you extubate them can really be, actually maybe that's why they have a sore throat. Avoid modifying your equipment. So, I've never ever cut the esophageal temp probe. We didn't do that, I think. If you were to go to court, for example, it'd be hard to defend what you've done if you've modified your equipment. And then avoid putting things in the nose. That was like the resounding message I got from attendings when I told them this story, is they just don't put things in the nose as much as they can. And then know your ASA guidelines. So Dr. Beck over at the VA encouraged me to go look at what are the exact recommendations when it comes to monitoring temperature. And you can see here I highlighted, it's kind of interesting, the wording. It's, if you anticipate significant body temperature changes. So I still think I would have monitored the patient's temperature in this situation, but just know that there's some unique wording on the guidelines. And then for our group discussion, either now or maybe we can wait to the end, just what is the optimal temperature monitoring? I realize in my mind, up until this case, I viewed shoving an esophageal temp probe in as really, really aggressive, and I kind of just viscerally didn't want to do it. But thinking through, what approximates core body temperature best while also striking that balance of not being too invasive. So be thinking about that, and we can talk about it at the end. So what happened, you guys kind of already know, he aspirated after a clot was in his airway from that intraoperative nosebleed and got a hypoxemic cardiac arrest. And Tom is going to do a really great job of explaining this more, but basically there's a tool developed where you just ask why, at least 5 times in a row, to help yourself get to kind of the core part of the issue. And that kind of allows you to fill out then a fishbone diagram, for example. So the first couple are obvious, but you got a nosebleed, and that's just partly from my lack of experience with nosebleeds. I was realizing I've never personally had a nosebleed. I was a medicine intern. I never rotated an ENT service to see just how profuse nosebleeds can be. I modified the equipment, and then I kind of already talked about this, but just provider bias. I was like, I just don't want to put anything in the esophagus. That's too much. And then recognizing too that the VA, so I didn't want to put something in the esophagus because it felt really aggressive, and then the VA esophageal temp probes are really not as stiff as ours, so it's very, very hard to thread them, so I also didn't want to use it for that reason. And then here's my fishbone diagram. I think some of the important ones to talk about is just for example, my individual staff factors. And this has been something I've been working on, and I encourage you guys, if it resonates with you, is just learning to like vocalize concerns. At the time, I should have said, hey, is there anything else I should be concerned about with this nosebleed? You know, like get resolved? Anything else I should be, was that like the normal amount for nosebleed? Like what do we need to do moving forward? Just recognizing that I had lack of experience, I've just learned more and more, like, you just gotta be humble enough to like ask questions. Stakes are too high, just ask questions. And then two, like I would say to the task factor guidelines, I realized I just had this like dogmatic need to monitor temperature, which may not be necessary in all situations. I think it was in this one, but just knowing, moving forward, for example, like a MAC case, you don't have to maybe aggressively get a temperature. I would say team factors, it was just important that the entire surgical team had left the room and we only had one nurse. So it actually took quite a long time to kind of assemble the group. The attending surgeon was actually in clinic. The surgery resident was off rounding on patients. So we actually didn't have them in there to help us troubleshoot stuff or problem solve stuff. And then I didn't have a vocera at the time. They have resident voceras now, but I didn't have a vocera. My attending had one, but he was busy intubating. The circulating nurse had one, but didn't know how to call it an anesthesia stat. So it took us a while to get a team in there. And then, as you can see here, let's see here. Yeah, team factors. So we got some trouble assembling the team initially, and then it was 3 p.m. at the VA. So it was funny how it got really busy, and then probably 7 to 8 minutes into the code, like the room got really empty again. So I would say towards the end of the code, then didn't have enough help. So not the most efficient code team. So I think those are some of the important ones. So in the future, how can we reduce the risk of this happening? I think it's just important to talk about it. I bet a bunch of you maybe haven't thought about this being a potential risk of a nosebleed. And then again, just recommend directly visualizing your airway before you extubate when there's been a nosebleed, or in nasopharyngeal surgeries or trauma where there's been bleeding, and then just thoroughly suctioning. And then how can we measure effectiveness of the changes proposed? I think we could potentially survey residents and doctors or residents and attendings if they're doing it. And then I even thought that we could instate like an EPIC event that said, confirmed a clear airway. And then especially after instating an EPIC event, we could collect and measure adverse events in the OR and PACU, before and after as a potential measure of if anything has changed. And these are references, particularly about kind of the perioperative cognitive aids. And then any questions? And this is my kitty. I thought I'd include it. We all need some cuteness. But do you guys have any questions or thoughts? Do you guys have any thoughts about particularly like temperature probes? Go ahead.
I guess the question I had is what's the incidence of a true coroner's clot? Like how many surgeries with nosebleeds? Do you ever find any information on that?
No. Yeah, and it's kind of historic at this point. A lot of the research was in pediatric TNAs, as you can imagine, about just meticulous hemostasis. I didn't see any other stuff,
I don't know if you looked this up or not. I was thinking, were there any other case reports of an esophageal temp probe causing a variceal bleed or something like that?
I know they're not benign either, are they? No, I didn't look that up. No, but I mean that's why I kind of wanted to have a discussion. Is I don't feel like any one is necessarily benign. The esophageal, you can definitely. It's either hard to get it down because you have a huge double lumen tube, or you can rupture things, or you can put it into the airway. Right. The nose one, again, I guess this could happen. The bladder, the bladder one's imperfect, right? If you don't have good urinary flow, it's not a good marker. Skin is certainly inaccurate. So,
why don't we use the bladder more? It seems like it's going in something, it's not more invasive because the Foley's going in already. Is it a cost thing?
I think my impression after leave is if you don't have good urinary flow, then it's not accurate as an approximate core temperature, I think. But I can in cardiac cases.
Yeah.
Patient positioning can be an issue also.
Yeah.
So if you think about it, it's floating on top of your,
Yeah.
So if they're in a very severe.
Yeah, so I think the purpose was just to make you guys aware that this could happen, to introduce you to cognitive aids, especially at Stanford Emergency Manual, to encourage you just to speak up and ask questions in the operating room. I know that I'm quieter by nature, and just that's I feel like an area of personal development for some of us to ask questions and speak up, to assertively say, nope, I'm not moving the patient over the gurney quite yet. I don't feel comfortable. There's I just have this gut feeling that something's wrong. Learning to realize when you.
Was Dr. Beck implying that you maybe need to monitor that patient's temperature at all? Because the guideline that you put there is like, I mean, we've all seen the temperature curve, right? Like your temperature drops in like, you know, by what is it, like 2 degrees in like 3 hours or something if you don't do anything, right? So that's an anticipated, like you're anticipating your temperature is going to drop, so you need to monitor it. Right?
Well,
so like
I
I
will
thought
tell
that
you-
was the ASA standard, like we need to monitor temperature because we all know that it's going to drop. Like
yeah, and that's actually, we should talk about that because kind of what was said to me was, we're going to do everything we can to keep the patient warm no matter what, even if we don't know the temperature. Like maybe you shouldn't have been so like insistent on monitor temperature. I mean, we should have just let it be.
If your patient is coagulopathic, sometimes it's nice to know why. Is it a problem with their tag, or like, do they not have enough nitrogen,
Right.
or are they 32 degrees?
Yeah. No, I know. I agree. So, I mean, again, now that I've kind of grown up and I'm
I
like
feel
looking
like
back.
there is nothing like I would have definitely monitored
Yeah.
your temperature.
Yeah.
So going off the cognitive aids we're talking about, when you start doing the PEDS for patients, they have a PD crisis app. They will make you down. And it basically gives you a quick run through. I think it's a great cognitive aid if you haven't, especially for the ones that haven't been over there. It's just called PD crisis. It's real self-explanatory. You pick the problem that's going on and it runs you through what else it might be, what you should look for, how to treat it. It's a good mental checklist, and the adrenaline is running along.
They had a last case over there, and you were talking about how sometimes the cognitive aids can be problematic because you get bogged down in them. And it's interesting what they did is they gave that to 1%, and it was that person's sole job to
Yes.
give like drug dosing and things like that.
To kind of be the person next to the team leader to like
Yeah.
talk in their
And
ear.
you
Yeah.
can enter adult weights in there. I had a patient I was concerned about last on OB. I put in 80 kilos and it calculates the right intra-lipid stuff for you. Like,
The PD crisis app is also useful, like not in just peds. It's like got a lot of like stuff that carries over to the adult setting. If you're like not looking specifically, you know, like drug doses and stuff like that. It's good to just like, oh, like what is the differential diagnosis for whatever this could be that I think it is or whatever.
And if you use it like Jess was saying, like you just like look at a couple before each shift or whatever, and then at least you're like familiar with how to get to it and like have it fresh in your mind.
Or look at after my first bronchospasm, I was like, what did I miss? What should I have been doing or thinking? Or, you know. And I like for me, I get nervous enough when this stuff happens that my mind blanks. So I will like literally, oh my goodness, you guys, I will literally like practice. If that were to happen right now, what would I do? Like just so it's just like mechanical what you do anyway. So those are some recommendations.
How big was this clot?
Like that big. It was big.
Was there any point that you thought you heard it aspirated?
No, not at all.
And do you feel like that was pretty immediate after extubation? Do you feel like it was boom boom, or do you feel like there was a period of time where
I think there was a
it
period of time.
okay?
I think there was definitely a period of time when it was okay. Because, the pulse ox is like 8 seconds to live. It was definitely more than 8 seconds. It was probably 30 seconds to a minute. Yeah. Why? What are you thinking?
I'm just curious, it's one of those things that we do obviously hear a bunch of pituitary surgery and we see clots a fair amount. And so that's one of the things that you have to consider. I think we tend to focus so much on secretions that are mucus, blood that you can suck up with your Yankauer, but you have to really think about clots because the Yankauer won't suck them up.
No.
So you have to really be thinking about that at the time of extubation.
Yeah.
Like, are they as dry as possible? Are there any possible clots that could be presenting themselves?
When you're DLing them, like you said, the few cases that you're really worried, you DL again right before you take it out. Like, are you doing it before they start emerging? Because I feel like that'd be really incredibly hard to do.
Yeah.
Wouldn't be too hard so long as you're not putting a lot of torque on it, right? You're not really trying to get a view for intubation. You're just trying to get a sense of is there anything there. So most times you can just slip it in and not really do a whole lot with it, so it's not that stimulating.
Thanks, guys.
Alright, I would encourage everybody to stand up, stretch it out. Yeah, it's been an hour or so.
Do you want your...
Oh, yeah.
Let me see? Did you take it out, or do you want
I
to
will
see?
take it.
All right, I'll stretch it out. All right.
Yeah, in the future, if that.
The thumb drive, or you know,
We were about to make a mission back. Oh no, the surgery won't be ready for an hour. And like quite a while later, they were like, oh no, they're still ready for another 30 minutes. And so, we were like, one yeah.
Hey guys, my name is Tom. I'm one of the residents here, like you guys. I was asked by Inga to talk about a case. This is going to be a new thing we do every month.
Revamping an old thing, but yeah.
Yes. So this is a case that happened in January here at UCH, and this is a nice picture I had from college. I thought, why make it a white slide? Like make it a nice slide. All right. So again, this is just like Jessica said. I'm gonna try to be non-judgmental. I'm not gonna include names. I'm just gonna I was asked to review case. I looked at the case, tried to understand what was going on. I had to ask Inga for some help because she was the provider in the PACU for this person. And then, so I'll kind of fill in all the details at the end. But again, like Jessica said, if y'all have any questions as we go, please stop me and ask the question. So first of all, the case, it was a 50-year-old guy. He has history of autoimmune polyglandular syndrome, so has type 1 diabetes. Gets about 70 units of insulin every day through a pump that he has at home with him, like on his belt or whatever. He has obstructive sleep apnea, uses his CPAP, and has multiple gastric neuroendocrine tumors. So coming in for a laparoscopic antrectomy, Roux-en-Y gastrojejunectomy. So kind of given his endocrine background, he had an endocrine consult. The team recommended having an insulin drip during the OR case, and it seemed like it was well communicated. And then they also recommended stress dose steroids and gave pretty precise directions for that. So I'm just going to kind of walk you through what I think are the most salient points of the case, not everything. The intubation was charted as difficult, needing a bougie. Otherwise, looks like grade 1 view with a CMAC. So whatever that means, you all are anesthesia providers. You know what that means, right? It's a CMAC video scope. You should get a grade 1 view, right?
We're not providers, we're doctors.
Thank you. Thank you. Please continue to talk. It's supposed to be fun and lighthearted, so no, I do encourage it. So this is the case. So it looks like this patient got 2 midaz. Looks like a typical induction. Insulin infusion was started at the beginning of the case and then stopped at some point. Antibiotics, ephedrine, normal saline, etc. So nothing looks too suspicious, right, when you're looking at this. And then looks like as we go, Sugamidex was given. Looks like Rock was given at induction, so Sugamidex is given at the end of the case. Zofran, opioids, and then looks like there's some dextrose given during this case too, if you see on the bottom row. So I'm going to highlight what I think is the takeaways here. So for the insulin infusion, basically what happened was this patient was given too much insulin. So somehow this patient was given a whole bag of insulin. A whole bag is 100 units of normal insulin. And that's obviously way too much for this patient. And then this patient was given more than 2 amps of D50 to, I would assume, correct that too much insulin. But it didn't really make sense to me because I'm like, oh, well, I looking through the pre-op notes, they recommended like giving an insulin infusion during the case, but then it was stopped, right? So it made more sense when I knew that too much insulin was given. So this is what's charted. And then looking at glucoses, so we have a pre-op glucose 108, and we had a 229, a low glucose greater than 600. The case looks like, so the induction was at around 14, 15, so the pre-op one was 108. After induction, there was a 229, and this, it looks like all the insulin, if, you know, this insulin infusion was stopped at 15 or so. And then we have a glucose after that, 229, and then low glucose, 45, 47, and then we have a very high one. We don't, you know, just like you are looking at this, maybe that's right, maybe it's wrong. I don't know anything about where it was drawn. Was it drawn out of a line with glucose in it, et cetera. And then as I keep going, so eventually this patient went to the PACU, right? So if we go back, the case ended around 15, right? Yeah, or no, I had the times wrong. So the times are wrong at the top for this slide, but it ended at some point, like we'll say 1700. So going beyond 1700, glucoses remain low. Inga told me that there was a dextrose infusion being run in the PACU. So basically, I'll analyze kind of what we know about the case. So we know that 100 units of insulin were given, patient required D50, and then a subsequent ICU admission. That was because the patient needed a continuous infusion of dextrose in the PACU.
So every 15 minutes it was dropping. Like if they would get D50 and then they would have to have a drop. So it was just needed higher level care.
I'm going to focus on a few of these tools to assess kind of what happens during an adverse event. So the 5 whys, just looking at Wikipedia, which, you know, as we all do. So I did know, I have a little bit of academic business education. So I knew about these things like Lean, Six Sigma, et cetera. The 5 whys is part of that. It was from Toyota. And as I bolded here, it's the basis of Toyota's scientific approach to repeating why 5 times. The nature of the problem as well as its solution becomes clear. So basically you say like, so vehicle did not start. Why? The battery's dead. Well, why is the battery dead? Well, the alternator isn't working. Why is the alternator not working? Well, the alternator belt's broken. So you just keep going, but you kind of drill down sequentially. And depending on what your first question is, it changes what root cause you find at the end, if you find a root cause. Water's good. This is my 5 whys. It's not from a very good source. It's from Tompedia. But so the problem is 100 units of insulin given. This is not perfect, and I just did it one time to kind of illustrate. But so why is 100 units of insulin given? Well, we found out that Alaris pump was programmed incorrectly. Why was it programmed incorrectly? Well, it was a basic infusion. Well, why was that? We're not really sure. Maybe the provider chose not to use the specific drug mode. Maybe they didn't know how. And then why? Maybe the specific provider was not in the OR commonly, main OR. So maybe they don't use Alaris pumps that frequently. So if you asked a different question at the beginning, like if your first question was, why was 100 units of insulin given? And if the first answer wasn't Alaris pump program incorrectly, then you'd have a different 5 whys, if that makes sense. You could find different root causes in that way. Here's my root cause analysis or fishbone diagram. This is the This is just the blank template. So patient factors, type 1 diabetic, individual staff factors, both the the APP and the attending are not usually in the main OR, so that's a factor. Task factor guidelines, there's no specific oversight, as we all know. Like we draw drugs up or hang them, and there's no one checking specifically what we're doing, like there is on the floor or in the ICU, for example, with nurses. Communication, I'm not sure about the team communication. Maybe it was a more complex setup. Maybe they were unfamiliar with drug dosing, administration. Maybe there's team factors. Maybe they needed some more support. As far as supplies and equipment, we found out like the Alaris pump and the tubing, maybe there was some issue with that. Education and training factors, maybe the person wasn't trained to use the Alaris pump. Working conditions, that goes back to the unfamiliar environment for these providers. Maybe there was stress from that difficult airway I mentioned, right? Like they probably weren't anticipating needing a bougie for this guy he has this syndrome but it's otherwise pretty healthy, right? You wouldn't typically need to use a bougie. That's kind of a stressful event. Maybe there's multiple infusions, right? You know you're going to give an insulin infusion. That's not typically what you do all the time, right? For a kind of maybe a straightforward case, you know. Maybe organizational. Maybe the APP felt uncomfortable saying like, I don't understand how to program the pump, or I'm not familiar giving insulin all the time. So there's a variety of things. I like the fishbone diagram. It's pretty helpful to think of different factors. There's this matrix from Vanderbilt. So basically, this is an example of it filled out. I didn't find it too helpful in this situation per se, but basically, you could think about ways in which the situation you encounter, the problem you encounter, is safe, timely, effective, efficient, equitable, patient-centered, and then kind of go through medical knowledge, communication, professionalism, systems-based practice. It gives you like a formal tool to evaluate each aspect on a grid, and then you can make at the bottom like an improvement or a plan to improve on each one. I thought maybe the 5 whys or the fishbone was more helpful in this situation, but this is a resource in the future when you all are doing something like this presentation to think about using. So what else happened, right? I didn't really give you all the details. So both the APP and the attending, not usually in the main OR, they had an unplanned stressful airway. There was at least 2 infusions on an Alaris pump. Nothing was labeled. I wasn't labeled on the pump, not at the patient connection. Infusions were programmed as basic. We found out there was an error. Maybe the lines were switched or the pumps were programmed backwards. So the best guess would be like someone programmed the insulin infusion at like a carrier rate, so maybe 50 or 100 per hour, and then the insulin, which was probably programmed at 1 ml per hour, which is what was charted, would be for the carrier, like normal saline or whatever. This was discovered when the provider that took the patient back to the OR went on a break, and the bag ran out, and there was like an alarm. The break provider was like, oh my gosh, why does it say air in the line? Oh my gosh, there's an empty bag of insulin up there. That's kind of my nightmare, you know, right? Like multiple amps of D50 were given kind of in that timeline that I showed you. Blood glucose was unstable. As Inga mentioned, this patient was continually requiring more dextrose in the recovery area, and then had a subsequent unplanned ICU admission. So really the idea behind this conference is to think about what we can do as a group to not have a problem like this in the future. So as I was going through this, some of the things that I thought were good points. So using the Alaris pump, we could use specific drug names when we're programming it. Double check infusions. So I remember when I'm on CT or liver, I'm always double checking my bags because I don't always hang, a bunch of pressors or other things. Just I'm always like, oh, how many milligrams are in how many mLs? And then is it really the drug? Because, it's in a little brown bag. It's you have to actually look, right? And then my tubing, and I have like all these tubes. Is this the tube that's actually going to the pump where I'm programming? It's just, again, it's kind of not a great system because it depends on us individually to look at all those points and make a decision. Is this the right thing? So be very careful, obviously. Label your infusions, so label them on the pump. From CT and from liver rotations, I've had a lot of success staying organized, just labeling both the pumps and the infusions when I connect them to the multi-connector, like the octopus or whatever we call it. If you're unfamiliar with the drug, device, et cetera, ask your attending, ask somebody, right? Because we all are unfamiliar. We don't do the same things every day. There's a lot of different procedures, a lot of different devices, drugs, et cetera. So you'd rather, it shows a lot of maturity on your part to say, hey, I don't understand this aspect. I want to learn. I want to do what's best for the patient. Prioritize effectively. Inga made this point that, is it really relevant to start the insulin infusion right away? Maybe the provider in the room was rushed, right? Maybe they felt like, oh my gosh, like this patient's diabetic. I really need to start this. Maybe they were rushing, So no, they really don't need 1 unit of insulin per hour to be started right away, right? It's something you're going to do during the case, but, take your time, try to think, be like, oh, if it's an emergency like Jackie's, like Jessica was describing, where it's like, I need to like code this patient. Yeah, like you should be calling for help. You can be acting quickly, but like if you're something like this, like slow down, take your time. If you're not in the same environment, obviously same thing, get help, familiarize yourself, double check. And then something like that would be really expensive would be like a double check system, like RFID tags or some other scanner system, right? So like RFID on the bag with the drug, on the pump, et cetera. So we don't have a system like that, but you can imagine something where there's a double check. So how can we measure the effectiveness of a change? So I thought about it in two pieces. So if we're measuring compliance with a change or measuring outcomes. So compliance with a change would be like, for example, if the change was providers must label all infusions, then you could do like a baseline and a survey every so often to see reports of how providers are compliant with your change. You could also do like a electronic documentation, right? So like during the case you document, maybe like in Epic when you're administering the drug, it'd be like, yes, and I checked the box that I labeled the drug, something like that. Then you could run statistics on that somehow in Epic. If measuring outcomes like drug errors, that would be something else where drug errors somehow either self-reported or subsequently reported somehow through the system, baseline data, ongoing data collection. So that'd be another thing. Any questions? This is when I went to the Cleveland Air Show in 2008. Yeah, that other one. That was from a few months ago. It's not meant to be a judgmental thing. I think we all make errors. It's meant to be like, how can we, like for example, Inga is on a committee where cases get analyzed. I'm not sure how many faculty are on committees like this, but it's something that you may do in your career, and it's something we're doing to allow us to present, but also to prepare us for the future when we're needing to analyze cases like this. So these tools are available. I think that's part of it too.
You have a sense? Go ahead.
Okay, I think it's interesting after giving a whole lot of insulin that patient was put on a D10 infusion intraoperatively. They were just giving like the bolus doses. And it didn't seem like the glucose levels were checked really that often after having run a whole diagram come in.
Yeah, there's no A line.
Yeah.
Yeah, those are all good points. So I would say the way this came to even the attention of the providers is that somebody was giving a break and the pump alarmed airline. They're like, what do you mean airline? They traced the tubing back up and the bag was empty. And they looked at the bag, it was missing. So the two big things were tubing got switched. So not only was the tubing not in the correct pump, but also that regardless of what was switched, both pumps were inappropriately pumped, like programmed as basic infusions. So a lot of things that came up with this were, one, I think, some people, especially when you're a CA1, you're more junior, so you have a lot of setup to do, you are in a cardiac room, you've got like 4 infusions to set up, there's just like pressure for turnover, and that's what kind of Tom and I were talking about, that I was like, okay, yes, we need to run insulin 1 unit an hour, but is it worth rushing through that when it's 1 unit an hour? It's not going to be like changing, right? So like, is it matter if I started before induction or after induction? Not probably, right? But this provider felt super rushed that they're not usually the main ORs. They felt this pressure, they set it up, it got torn down accidentally by the people who turned over the room, which you're not supposed to have those on different patients anyway, in different cases. But again, like I think a lot of us don't label things when it's like one thing hanging. So like we put a phenylephrine infusion up, right? We don't label it on top of the program pump. We don't label it where we plug it in. And so I kind of have this philosophy that like, I have everything labeled in my room that if I call for an emergency, I don't have to tell anyone what anything is. That when they run in there, they know which line is where, they can do, so that somebody, you kind of treat it like, what if you're going to pass out? Can somebody come in and pick up your case pretty quickly, right? And so I think this was a really good example of someone who's not in a familiar environment, didn't ask for help, or didn't feel that the person that was there attending had said training to help out as much either. And then just really, the person's used to program basic infusions, and the whole reason we have a Lair's pump program the way it is that if you put in a value outside the norm, it's going to be like, hey, are you sure you really want to do this? And so it's kind of that just extra check for everyone. And so I think it's really important just to like kind of go through, for this person, it was kind of a Swiss cheese model. All these things aligned for this case, and they were so worried about this plan of 1 unit per hour that had been laid out so thoroughly and ingrained in them that endocrine was like, you must do this. That kind of made them lose sight. It was like the tree for the forest, right? And so I think that was a big thing. And then the other thing we often do in these QI meetings is we call it substitution model. And I know Tom and I talked about this. So it's like, if Tony or I were doing a case and saying like, I do something, they're like, well, Tony, if you were in the exact same situation, would you potentially cause the same, like do the same thing? And so what was really interesting to me is that actually some of the APPs went around and said, yeah, I could totally easily switch tubing, in the pumps. And you're kind of like, whoa, like, I don't think that's a common thing. So I think, again, sometimes you just need to take that extra minute and make sure, like, trace your tubing. When you're programming the pump, look at the bag, follow that tubing down, especially if you have, I see patients come down with 8 pumps, 8 bags hanging, you're switching things out. So I just thought this example, this case was like a really good example of how a lot of things can line up and make a risk. This patient did fine. I mean, he was alert talking. It was more annoying to him that he kept getting poked for his blood sugar. And I just became aware because I happened to be the C1 and took over vacuum care for him. But I think this case just overall covers a lot of things when you're starting out in your more basic cases that you can ingrain yourself to prevent some of these issues and bigger cases down the road.
So quick, last year one of the QI groups did pre-labeled all vasopressors. And I know Clark was saying pharmacists weren't out there. Some easy labeling. Like go to labels first for that. But insulin's also a very high risk medication. Someone uses vasopressors.
Another one too that I made a mistake and swapped because they put Precedex and vasopressin in that stupid same big syringe. They look exactly the same, and I programmed vasopressin as Precedex.
So I think just for all those things, when you're dealing with medications that are particularly high risk of vasopressors, or insulin. All these
Well, I think
it's really heavy pharmaceuticals.
I think the other thing, like, for things, so I know phenylephrine is always the same concentration here, but I still grab that bag and look at it every single time.
Yeah.
Because it can help prevent like the Precedex versus vasopressin switch, because if you look at it then you realize, whoops, that's something different. So I don't know, I start at the top and look at the bag, follow it down, program it into the pump, and then place it into the doctor was.
So, and the one other thing I think that's really came up with this separate is that there was no charting. So Tom called me, he's like, I don't see what the problem is. There's an insulin infusion, they stopped it. Like, yeah, no, what's the point of this? So, this is a big oops, right? And documentation is everything. So if you're in the court of law, if you didn't document it, it didn't happen. So the fact that there was not even a quick note put in, that there was not even, there were really no things that were put in to really identify this is what happened, this is what we did. So I think yes, it's an error, but you still need to document what happens, right? Because again, somebody else may be ending up taking care of that case, and time points are really important in these situations. So I think it was really interesting, because when it came to us, when it comes to me, somebody's already investigated it. So I have they've talked to other people, I get all the details. So I never physically opened the chart before. So it's funny when Tom called me and I was like, let me fill in the blanks. So I think it is, I know some people kind of like, oh, we don't want quick notes every 5 minutes. But I think some of them are very valuable. So I know when I work with some of you guys, my attorney is prone, and if I'm not controlling the head and neck with the neuro case, I put a quick note. Like, patient home prone, head and neck controlled by surgeon, maintain neutral. Or when I turn 180 in EMT cases, those are time points that if something happens, then it can also clarify, what if my A-line gets ripped out, and then it's well, they turn 180. So it's sometimes for some people, I think it feels like an over-documentation. But again, it is always better, I think, to over-document than under-document.
Yeah, I want to echo that point. We've had a couple of issues that have come up with resident documentation at some locations, and I think that's something that the timeliness of it, so when you're giving something and what else is going on during the case, those are important pieces that you have to have in the chart. Because if something bad happens like this goes to a lawsuit, you go to court, you're going to ask those people that were in the OR, well, you said you started this infusion at this time, but you didn't check glucose until this time. Why did you wait 30 minutes when you knew that the whole bag had been infused? So things like that, right? If you can't defend the timing in the chart, then you're screwed. And so it's very critical for you to make sure that you are accurate about the order with which drugs are given, when things happen. The first case that Jessica talked about, when the patient starts to code, for example, what's done during the code, all those things are really important pieces to include. So documentation is something that you have to do really well. And when you finish, if you get into an environment that you're either solo provider or you're going to be supervising, you have to fill in those blanks if whoever's in the room doesn't do that. So oftentimes when I work with residents and we have things that take place, I say, hey, make this as thorough as possible, and yet I still have to go back and put in additional information. So that's an ongoing process of just learning what to include, how much to include, but that's really important. The other thing I want to say is for these infusion errors, insulin's not something we do a ton of for infusions, but things that we do regularly, propofol, sometimes sufentanil, Precedex. I think one of the ways that you can protect yourself a little bit from these over infusions is to pay attention not just to what you've programmed in for your rate, but also the green number that pops up that tells you how much of that solution, cc's per hour, is going in. So you start to then make a relationship between, my propofol is set at 200. I have, let's say, 30 cc's going into the patient per hour. That makes sense. So that you look at that top green number and you say, well, it's 60. Oh, wait a minute, I didn't program it to be that high. So it forces you to double check. So I think that's one additional number that you should look at and try to get a sense of what is a normal range of cc's per hour that are going into this patient, in addition to whatever you programmed in as well.
Any other comments or questions? Cool.
Good job.
Thanks, guys.